Welcome to Hearing Education Series presented by the Ear Research Foundation. Today's webinar topic is hyperacusis or noise intolerance. We are joined by Dr. Herbert Silverstein, President and founder of the Ear Research Foundation. Dr. Silverstein is a world-recognized expert in hyperacusis and has developed a minor surgical procedure to reduce hyperacusis. Before turning the webinar over to Dr. Silverstein, please be sure to keep yourself on mute during the presentation. If you have questions, please submit them via the chat below. Questions will be answered at the conclusion of this presentation. Again, I would like to thank you all for joining. For more information about our organization and how you could help our mission of research, education, and community care to ensure we can continue to provide educational webinars to all, please visit earrf.org. Now here's Dr. Silverstein.
Thank you, Christina. So today we're going to talk about hyperacusis. This is a subject that I became aware of actually not too many years ago. Actually, 2009 was the first patient that I saw with hyperacusis. And we'll go through the story. The four types are hyperacusis, recruitment, misophonia, and phonophobia. And we'll talk about each one of these things. So hyperacusis is a condition where a person cannot tolerate normal sounds. They become very anxious and avoid places like movies, restaurants, and sporting events. It often affects their quality of life, and many of them become recluse, don't want to get out and talk to anybody, and their lives are actually pretty miserable. Supposedly, this affects 6 to 17% of the population. This can occur when there is normal hearing or actually a sensorineural hearing loss. And the way we determine whether you have hyperacusis or not is to test your uncomfortable loudness level. And most of the patients are below 90 dB. Normal is between 90 and 100. Most normal people can tolerate that much sound. Tinnitus or ringing in the ear is associated with about 40% of the patients. The patients treat themselves with earplugs. There's tinnitus retraining therapy, TRT, cognitive therapy, long-term treatment usually is required, and the results are variable and may not be effective. Now, recruitment is the second type of hypersensitivity, and this occurs mostly in patients with Meniere's disease who have a hearing loss. And what happens when the sound gets to a certain level of their hearing loss, they get a sudden increase in threshold, and they hear the sound very loudly. And this is seen, again, in patients with increased pressure in the inner ear from Meniere's disease. The treatment is the same as for hyperacusis. The third type of hypersensitivity is hypersensitivity hearing on certain specific frequencies. This is commonly seen in autistic children, and the treatment is auditory integrative therapy, or AIT. Phonophobia is a fear of sound. Misophonia is a dislike of sound. You can remember when you were a child and you were listening to the chalk scratching on the chalkboard, how unpleasant that sound was. Usually the LDLs or loudness discomfort level is normal, and patients may need psychotherapy to get over this. So what is the cause of hyperacusis? Most of the patients, or half of them, the cause is unknown. Head injury seems to be very common, or cochlear trauma due to sound blast in the ear. Superior canal dehiscence, which is a decrease of bone over one of the semicircular canals, seems to be associated with hyperacusis. Perilymph fistula which is a leakage of fluids from the inner ear, can cause hyperacusis and adverse reaction to certain medications. And recently, as we'll show you on our videos, we found hypermobility of the stapes, or the third bone of hearing, which has been a new finding in the last 3 or 4 years. So the possible mechanisms of hyperacusis is impaired neuroplasticity and noise suppression, our hypersensitivity of the cochlea to sound, our hypermobility of the stapes. So looking at the literature, there actually was only one paper when we first started doing this, which showed a patient that had hyperacusis with the superior canal fistula, and when she had surgery to close the windows, the round and oval window, the hyperacusis went away. There's been no previous literature reporting round and oval window closure reinforcement for hyperacusis. So the first patient, WS, was seen in 2009. He was involved with a loud blast from an explosion, and his one ear was traumatized with a tear of his tympanic membrane, and the left ear, he developed noise intolerance. It was driving him crazy, and he didn't know what to do about it. And actually, I didn't either. But I asked him if I said, we could try to put some tissue in your ear that would dampen the little bones of hearing that may make the symptoms less. And in this patient was willing to undertake an experimental procedure where we took some tissue and placed it on the round and oval windows, and he was significantly improved. So this shows you the tissue that's placed all around the stapes and the round window, and to decrease the sound pressure going into the inner ear. And in this one, you can see the tissue over the stapes here. The second patient was seen 5 years later, actually, in 2014. This patient had hyperacusis for years. It impacted her quality of life. She had to avoid noisy places, and she asked to have something done, and I told her about the procedure that we had done before, and she agreed to go under the procedure. The right ear was operated first, and after that surgery, she was asked to have the left ear be done because she was so happy with the result. So this is how we do the procedure. We take a little bit of tissue from above the ear. It's called fascia tissue. It's overlying the muscle. And we use a little biopsy punch and make little round circles of the tissue so that we can place that in the ear. So I wanted to show you this hypermobility of the stapes. Here you can see us showing the hypermobility of the stapes. We're touching the incus bone and the stapes. You can see the stapes is more mobile. Motion has more motion than normal. We're going to talk and show you the procedure from the beginning. Now we're raising a tympanomeatal flap and elevating the skin and the eardrum so we can look into the middle ear. This is a left ear. We can see the round window down on the left and the stapes on the right. Now we're using the little dermatic tone punch to make the circles of temporalis fascia that we're going to place around the stapes and the round window. We use a 2 millimeter punch and a 4 millimeter punch. Several pieces of tissue are placed on the round window, and then a small piece of gel foam is placed to hold the tissue in place there. So the round window is now being reinforced. Next, we'll be taking tissue, a small 2 millimeter piece, and placing first piece on the stapes foot plate. We usually use 10 pieces of tissue packing it all around the stapes, crura, and the wood plate of the stapes to try to decrease the mobility of the stapes. Now we're putting the drum back in place. This will show the procedure. So we're showing how the little stapes bone, this is the incus bone that I'm touching with an instrument, and that's the stapes bone that's being moved around. The stapes should not be moving that easily. And the portotympany nerve, or the nerve of taste, is running over the area. So we've used electrical stimulation that'll show that the movement of the stapes is very loose. It shows the stapes contracting there. You can see it going back and forth. So you'll see what happens after we put tissue around the stapes and oval window. Now you can see that the stapes is moving a lot less. The patient's symptoms were markedly improved by doing this procedure. Now we're stimulating again to show you that there's less movement of the stapes through the electrical stimulation. So we did a prospective study of 20 adult patients, age 18 or older. And this was an IRB approved procedure and study. And what we did was we measured the patient's hearing. We did the LDL test, their loudness, discomfort, did a CT scan of the temporal bones to be sure that there was no fistula of the superior canal. And they had to fill out a hyperacusis questionnaire, a tinnitus handicap inventory, and a hospital anxiety and depression scale. So we measured the patients before surgery and at 4, 24, and 52 weeks. So 6 months result, 10 patients or 14 years. 7 out of 10 patients reported subjective improvement, noisy situations. 1 patient with misophonia was not improved, and 2 patients with very low ULLs of 50 and 60 dB were not improved. But there was noticeable improvement in the opposite ear being operated. And patients with bilateral hyperacusis asked for the second ear to be done when it was severe. Some patients did not need the surgery on the second ear. And there was no subjective hearing loss from putting the tissue on the little bones of hearing. So we went back and looked at all our patients at 2022. We called 70 patients and 81 ears. 31 patients responded to our survey, and 29 out of the 31 would recommend the surgery. The average preoperative severity from 1 to 10 was 9.3. This was decreased in severity to 4.7. So in conclusion, there's marked improvement after the first ear surgery. The unoperated ear improves, may not need a second ear surgery, but the tinnitus was unchanged in any of these patients. This was a picture of the first patient that we wrote. We've written 4 papers that are available on Google if you want to check those out. And on our website, we again show the surgical procedure and answer any questions. And there's some testimonials on our website. So we'll open it up to questions at this time.
The first question. If anyone has any questions, you can submit them, and we are going to start answering them. Okay, the first question is, does age matter?
Good question. In adults, this could work out well. In children, we're not sure about. We were thinking about doing a study on autistic children. We're not sure whether that would work either on those children. But most of these patients that we've operated on have been over 18 years of age, and mostly have been adults.
Okay, the next question is, have you treated patients with loudness hyperacusis who got it from prolonged exposure to loud sounds rather than one loud incident?
Yes.
And what was the outcome?
Yes. It's interesting, the outcome does not seem to be related to what caused the injury. So we have really not studied that in great detail to try to correlate the injury and the result. Since most of the patients get a good result from the procedure, I don't think it matters what causes it.
Okay, the next question is, what was the span of ages in your studies?
18 to probably 70, I'm guessing. If the patient can undergo anesthesia, the age does not matter.
Okay, the next question. Have you done this on anyone with a cochlear implant? I didn't start having hypersensitivity to sound since CI surgery in October of 2020.
No, we haven't. And I'm not sure that it would work in that case, because the problem is with the electrode stimulating the nerve and not the little bones of hearing stimulating the inner ear. So the operation that I developed is designed to reduce the motion of the little bones of hearing and decrease the sound going into the ear. So I doubt if it would work.
The next question is, are you currently doing another study now?
We're always evaluating our results, and probably soon we'll be looking at the whole series to see how long the surgery lasts. And it's very interesting that it seems that if the surgery works and the patient is happy, it seems to remain for a long period of time. It remains for years, and many of these patients we don't see again with complaints of hyperacusis.
Okay, the next question is the cost of the procedure and how many days need to be factored in for the surgery, pre and post, and is a surgery successful for pain hyperacusis patients?
Another good question. It works very well for the pain, and I don't understand why it does, but it does. It seems to help. It's helped almost every patient that has had pain in the ear. Regarding the time, usually the patients come in several days before the surgery and get tested and get evaluated. And then surgery is done and they stay in the area for a week, or they come back in a week to have the packing removed. The cost of the surgery runs about, I think, around $10,000 for the everything, for the hospital and the surgical fee and the anesthesia. But I'm just estimating that. I'm not exactly sure of that. And insurance many times covers the procedure.
The next question. Do you have suggestions for people with hyperacusis and cochlear implants if the surgery you designed is not an option?
Sorry.
Have you distinguished in your patients different results in loudness versus pain?
Yes, I answered that a little earlier. It seems like the patients with pain get a good result. You can almost tell them that for sure they're going to have less pain after the procedure.
Okay, the next one. Are you finding that more people are coming forward with hyperacusis? Do you think it is more prevalent now with the noisier world we live in? On that matter, in your opinion, do you think that the legal decibel level should be reduced?
We're definitely seeing a lot more patients with this, and I'm not sure whether it's because we've taken an interest in it and we've operated on patients and developed a procedure, or whether it's becoming more. I have the feeling that it's getting more common because of the loud noise that people are exposed to, and head injuries seem to cause it. And definitely seeing a lot more patients with it than in the past.
Okay, the next question. Having hyperacusis doctors tell me to do sound therapy. I try to extend, but it's very painful and difficult. Other than surgery, what are things that could help? I have custom earplugs with a dampened filter.
That's the best thing that you can use right now is ear protectors with sound reduction. There's the therapy. The audiologists like to do therapy for these patients, and it's a long-term therapy, and sometimes it works and sometimes it doesn't. Obviously, if it doesn't work, they can have the surgery, or if they don't want to wait for months through the therapy, they can have the surgery. Surgery is a minor procedure, very little pain associated with it. The patient essentially lives a normal life after the surgery, can do anything they want pretty much except swim. And it's interesting that the few patients where it hasn't helped them, they've recommended the procedure anyway. And it's if it doesn't work, and it usually doesn't cause any damage to the ear, and it doesn't hurt the person. So if it's bothering the person to the point where it's affecting their life, then it's probably worth doing the surgery.
Okay. The next question is, do you know of anyone else doing the same type of surgery nationwide?
Yes, there are a number of fellows that we've trained here. We've trained 49 fellows now, and the ones that have been here after I developed the procedure in 2009 all know how to do this procedure.
Okay. Is there anything to do with if the hypersensitivity seems to just be a certain low sound at night when it's very quiet? It isn't tinnitus. It comes from an outside sound. There's no pain. I use earplugs and that helps.
Yeah, that doesn't need surgery, that kind of problem.
The next question is, does this impact tinnitus?
No. Unfortunately, the procedure does not help tinnitus, and that will have to be treated separately from the hyperacusis. And that, incidentally, that does respond to tinnitus retraining therapy and other treatments for tinnitus.
Okay, the next question. How does one go about getting the surgery, and what are the costs?
Again, Not sure 100% exactly what the cost is, but it's around $10,000. And the best way is to make an appointment and get evaluated. You can have that evaluation on the telemedicine, and then we schedule the patient to come in. And we have patients coming in from all over the world for the surgery. So we're set up to do that.
Okay, the next question. Could there be different mechanisms and etiology of hyperacusis other than hypermobility of the stapes?
Yes. Yes. Definitely.
Okay, any more questions? Okay, the next question. Does the surgery help with ear fatigue as my hyperacusis is part of noise-induced cochlear neuropathy?
Not sure about that.
What different mechanism for secondary gain? I believe this might be a follow-up question. We'll go back to that so I can read them together. Is there a direct line to call? I was in a car accident and have brain damage. I get navigated to weird places. Yes, you can call. You can email through our website if you wanted to set up a consultation.